Hello friends, so this is a Quinoma session from Chambers, and today we will be having a rapid review of the gastrointestinal tract drugs, okay, the gastrointestinal tract pharmacology. So we'll be having a one-liner and mostly some conceptual based, one word answer. So this is actually a live session, and my students who are joining this session can send the answers on the chat box and we can let you know the right answer or wrong answer. Okay, so let us begin then. So the first question is, what is alkaline tide? What is alkaline tide? Alkaline tide means, so what is an alkaline tide? Alkaline tide means whenever you are taking meals, or for example you have a vomiting, what happens is your blood pH increases. It because once you eat something, your gastric acid is secreted into the lumen, isn't it? So once gastric acid gets secreted into the lumen, your blood pH will rise, isn't it? It will go towards the basic side. So that is called as alkaline tide. Okay, that is called as alkaline tide. So can you tell us the mechanism of action of H2 blockers? Mechanism of action of H2 blockers. Some people are writing block H2 receptors. Well, the way to is to reversibly block the H2 receptors. So H2 blockers, they are reversibly blocking the histamine receptors. If they are reversibly inhibiting the H2 receptors, then it will lead to decreased proton secretion, isn't it? Decreased acid secretion, and acid is secreted by parietal cell. Okay. So can you tell us what is the use of H2 blocker? Where do we use the H2 blockers? We use it in peptic ulcer disease. We use it in gastritis. We use it in mild esophageal reflux disease, isn't it? So we are using that. Can you tell me some H2 blockers? Name some H2 blockers. Name some H2 blockers. So H2 blockers we have taught you, that is cimetidine, ranitidine, famotidine, roxadidine, nizatidine, and loxatidine, isn't it? There are so many. So cimetidine, famotidine, nizatidine you can remember. Okay. Can you tell us why cimetidine is not used in the clinical practice now? Why we are not using it routinely, like why we are not using the cimetidine? Okay, very nice. So it is able to cross the blood-brain barrier and that will cause mental state changes. So what else? It has a side effect of impotency. So what is impotency? I've taught you. It inhibits the DHT binding to androgen receptors. That leads to impotence. Which is the most potent H2 blocker, by the way? Which is the most potent H2 blocker? The most potent H2 blocker is famotidine. Okay. So can we name a H2 blocker which is having the anticholinesterase activity also, which causes bradycardia and nizatidine? That's a beautiful answer. Nizatidine is the beautiful answer. So which H2 blocker is having the highest bioavailability? 100% bioavailability. We have learned it in pharmacology lectures. So that is nizatidine. Nizatidine is having the 100% bioavailability. Okay, nizatidine is having the 100% bioavailability. So can you tell me what are the side effects of which question should I ask? Okay, tell me what is bismuth? Bismuth sucralfate. What is a bismuth sucralfate? Please type your answers. Beautiful answer. It's a ulcer protective agent. So it actually, what is the mechanism is, it binds to your ulcer base and it provides the protection, actually a physical protection. Okay, so when it provides this, it establishes your that pH gradient in the mucus layer. Okay, so remember that. And why we is sucralfate affected by acidic environment? Is sucralfate affected by acidic environment? No, it is actually good that we should have a acidic environment, isn't it? Sucralfate requires actually the acidic environment. So can I give sucralfate with PPI, proton pump inhibitors? No, I can't give, because PPIs will decrease the acid secretion in the stomach. Can I give it with the H2 blockers? No, I can't give it with the H2 blockers. Why? It decreases the acid production, so I should not give sucralfate in the with these two drugs. Okay. Where do you use this sucralfate bismuth therapy? Where do we use? We use it in healing of the ulcer. We use it for in the quadruple therapy for H. pylori infection, isn't it? H. pylori gastritis. Or we are using it in traveler's diarrhea, isn't it? Mostly the bismuth is being used in the traveler's diarrhea. Okay, very good. So can you tell me what is misoprostol? Misoprostol. Misoprostol is basically a prostaglandin E1 analog. It is a prostaglandin E1 analog. Means it will increase the production of mucus, gastric mucus, and also its secretion. It will increase both the production and secretion. Okay, that means the acid will be getting decreased acid production. Very good. So can you tell me where are we using this misoprostol? Where are we using this misoprostol? Yeah, beautiful answer, for the NSAID induced peptic ulcer. And what else? We are using it in ripened cervix. Ripened cervix. What is ripened cervix? Induction of labor. That I will be teaching in the gynecology lectures. Okay. So can you tell me any one of the adverse effect of misoprostol? It is adverse effect is diarrhea. Adverse effect is diarrhea. Okay. So can you tell me something about aprepitant? Aprepitant. Aprepitant is basically a substance P blocker. Substance P blocker. What does it do? It blocks the neurokinin 1 receptor in brain. Neurokinin 1 receptor in brain. Okay. So where are we using this aprepitant? We are using it as an antiemetic. For if we are giving chemotherapy to a patient, for example, of a carcinoma, the chemotherapy induced, there happens a phenomenon that is chemotherapy induced nausea and vomiting. So to prevent that chemotherapy induced nausea vomiting, we are giving aprepitant. Okay. So what is metoclopramide? Metoclopramide is basically a D2 blocker. It is a D2 blocker. Okay. What does it do? What is the mechanism of action? Yes, please. It is a D2 blocker. What is the mechanism of action? Yeah, D2 blocker is the mechanism of action, but that is actually the place, the site. But what is the mechanism? How are we using it? So actually we are using it for the in case of diabetic gastroparesis. Diabetic gastroparesis. We are using it in diabetic gastroparesis, or we are using it in post-operative gastroparesis. Okay. Or you can use it as an antiemetic also, or you can use it in patients who are having persistent or a long lasting gastroesophageal reflux disease. Okay, but what is the basic mechanism? It actually increases your gastric emptying, because in diabetic patients there is basically a gastropathy, isn't it? There is a diabetic gastropathy, that things are not able to be getting emptied. So what we are doing is we are giving a D2 blocker where we are increasing the gastric emptying. But remember, you know, in the transient time of the colon, it has no effect on the colon transport time. Okay, so remember that it has no effect on the colon transport time. Okay, so can you tell me what is the adverse effect of metoclopramide? It causes tardive dyskinesia. The adverse effect would be tardive dyskinesia. It causes Parkinsonism. We will have a Parkinsonian effects. Okay, because you are blocking. Why? If it is causing it can cause as a potential to cause Parkinson disease. That means it's able to lead to block, isn't it? So can also precipitate seizures. Why? Because decreases the threshold of seizure. Okay. So what will be the contraindications of metoclopramide? Contraindications, where will I be not giving this? If I have a small bowel obstruction, because what I am doing is I am blocking the D2 receptors and I'm increasing the motility, I'm increasing the contractility. But if a patient is having a small bowel obstruction, it will be perfectly contraindicated. I don't want the things to move if there is an obstruction. Okay. Can you tell me something about orlistat? Orlistat. What is orlistat? It is basically an enzyme inhibitor. Which enzyme inhibitor? Gastric lipase inhibitor. Also, what does it inhibit? Pancreatic lipase. That means will it decrease the absorption of dietary fats? Yeah, it will decrease the absorption of dietary fats. Okay. Okay. So can I say it is helpful in weight loss? If I want to lose weight loss. Yeah. Okay. What else? What else? What can be the adverse effect of orlistat? It causes steatorrhea. Steatorrhea means fatty stools, isn't it? We are not increasing the absorption, you're decreasing the absorption, so the things are going to come in the stool. By the way, also there will be the deficiency of fat soluble vitamins. So what are the fat soluble vitamins? A, D, E, K are the fat soluble vitamins. Okay. Can you tell me about docasate? What is this docasate? What is docasate? Docasate is an emollient. Docasate is an emollient. What does it do? It increases the fat and water in stool. Okay, but there's a problem with its use, because it's a laxative. Actually, it's a laxative, isn't it? It's a laxative, and there's a problem with its use. What is the problem? The problem is that it causes diarrhea, and it can also cause metabolic alkalosis. Okay, metabolic alkalosis. So can you tell us some osmotic laxatives? Can you tell us some osmotic laxatives? Beautiful answer. That's a beautiful answer. So what are the osmotic laxatives? They are magnesium hydroxide, magnesium citrate. I can remember one also, L-lactulose, and PEG. PEG is polyethylene glycol. So what is the mechanism of action of osmotic laxative? It increases the osmotic load, meaning thereby the water in the GI lumen will increase. So what is the other use of lactulose? Can we remember something from our basics of pharmacology, which I taught you in my lectures? It actually is used in the hepatic encephalopathy. Lactulose is used to treat hepatic encephalopathy, because my gut flora is degrading the lactulose into lactic acid, acetic acid, which will lead to excretion of ammonium ions and H4 positive ions, isn't it? And it can cause, what can osmotic laxative cause as an adverse effect? It can still cause, if you overuse this, it will cause metabolic alkalosis, and I can think of dehydration, I can think of diarrhea, and what else? Bulimia nervosum, I have taught you, isn't it? So if it's misused by the patients, it will be causing bulimia nervosum. Okay, are we clear? So can you tell us something about loperamide, the famous drug loperamide? It's an opioid. Okay, very good. And what else? Basically, if I want to say, I would say it is an opioid what? Opioid agonist. It is an opioid agonist. Okay. What does it do if it's an opioid agonist? It decreases your gut motility. Your gut will have less motility. Okay. What can I use with loperamide to decrease the addiction potential? How to decrease? How to decrease the addictive potential? Beautiful answer, Sunana. That's an atropine. Atropine should be used with it. Okay. So can you tell me what are the drug of choices for which diseases can I use PPI? PPI is drug of choices for many diseases. I taught you in a mnemonic. GZP. What is GZP? G stands for gastroesophageal reflux disease. Z stands for Zollinger-Ellison syndrome, and P, peptic ulcer disease. But remember, if there is a peptic ulcer disease due to any etiology, if you have peptic ulcer disease due to any etiology, due to any cause, for example, NSAID, for example, H. pylori infection, you can give PPI as a drug of choice. By the way, what are the therapy for H. pylori infection? What are the therapy? How to treat H. pylori infection? Yes, kindly contribute. So I have taught you how to speak when the treatment you have to speak for this. So we have two therapies. We have standard triple drug therapy and we have standard quadruple drug therapy, isn't it? And then we said if we want to eradicate the H. pylori, we will be first looking which areas is having the low clarithromycin resistant and which area is having the high clarithromycin resistant. So if the areas where you see low clarithromycin resistant, then you should give only the triple drug therapy. And if the areas which have a high clarithromycin resistance, that we will be giving a quadruple therapy, that is 4 drugs. Triple therapy 3 drugs, quadruple therapy 4 drugs. Triple therapy includes, what does it include? You have to treat the patient for 14 days. 14 days, the treatment will be for 14 days, and standard quadruple therapy will be for 14 days too. But the difference is, and difference lies in the drugs. So you will be giving clarithromycin 500. So if I write a table for you, clarithromycin 500 mg, amoxicillin 1000 mg. This is a triple therapy, okay? This is a triple therapy. So amoxicillin 1000 mg. But if the patient is allergic to penicillins, then we will replace it with metronidazole. So metronidazole will be 500 mg and lansoprazole. Lansoprazole will be 30 mg. So this all therapy is to be given BD 14 days. Okay. And if I see the areas with high clarithromycin resistance, I will start with quadruple drug therapy. So the quadruple drug therapy includes lansoprazole, bismuth substrate, tetracycline, because it's a quadruple, isn't it? A 4 drug therapy. So tetracycline and metronidazole. Okay, this would also be for 14 days. And lansoprazole, how much? 30 mg BD. Okay, bismuth substrate, how much? 120 mg QID. And tetracycline will be 500 mg. How much? QID. And 500 mg TDS. I hope this is clear. Yes, dear students. Okay, very nice. So let us move to the next question. What should I ask the next? I think I should ask about the, can you tell me the inducers of proton pump? What things physiologically induce the proton pump, stimulate the proton pump? Yeah. Fast. The answer should be fast. Okay, let me say. People are not replying. So histamine, acetylcholine, and gastrin. So on which receptor does the, which receptor? Yeah. So histamine, acetylcholine, and gastrin. Okay, gastrin via the CCK receptors. Okay. Okay, another question. Can you tell me some monoclonal antibodies for Crohn's disease? Some monoclonal antibodies for Crohn's disease. So for the Crohn's disease, the monoclonal antibodies are vedolizumab. Okay. Have I taught you that in the previous lecture? I hope so, isn't it? So vedolizumab and natalizumab. and certolizumab. What else? Adalimumab, infliximab. Okay, is it okay? What is the route by which we give infliximab? We give it an IV. Infliximab is given IV. I for infliximab, I for IV. Okay, easy. Okay. Can you tell me what is the first line treatment for mild to moderate ulcerative colitis? What is the first line treatment for mild to moderate ulcerative colitis? It is, yeah, 5-aminosalicylic acid. 5-aminosalicylic acid. Okay. It's the first line for ulcerative colitis. Okay. Are we able to remember or listen? Yeah. Can you tell me some prokinetics? Name of some prokinetics and their receptors? Can you tell us the name of some prokinetics and receptors? So, prokinetics, which prokinetics we have? You should not open your book, but you should use your brain. Okay, use your hippocampus. I don't want you to be, I don't want you to be, reading it from the book or something. You should remember from your brain. So I have a prucalopride, that is a 5-HT4 agonist. I have macrolides, that is from antibiotics, also the erythromycin, and D2 blockers, what is metoclopramide and domperidone. At least you can say these. Okay. So can you tell us what is the treatment of irritable bowel syndrome? What is the treatment of irritable bowel syndrome? If irritable bowel syndrome is having diarrhea, patient is having diarrhea dominant irritable bowel syndrome. So for diarrhea, you will be giving loperamide or what else? Allocetron, isn't it? You can give that. For if it is constipation dominant, then laxative and prucalopride you can give, isn't it? There are many drugs. I'm giving you 2 or 3 just so you can remember these. And to relieve pain in IBS, what can you give? You can give anticholinergics or you can give reuptake inhibitors, isn't it? TCAs. So next question I ask you. So can you tell me what are prides? If I see some drugs which have prides with it, which drugs are those? Very nice answer. Cisapride, mozapride, enzapride, procalopride. So these are 5-HT4 agonists. 5-HT4 agonists. Okay, not 5-HT3. It's 5-HT4 agonist. Okay. So can you tell me what is the, if I give it with, what is the adverse? Well, can you tell me a heart side effect of cisapride? It causes QT prolongation, isn't it? Isn't it? Can I give cisapride with ketoconazole or erythromycin? No, I cannot give. Why? Because because they are the inhibitors of this enzyme CYP3A4, isn't it? Causes torsades, isn't it? Torsades, the points. So what is dronabinol? What is dronabinol? Dronabinol is a cannabinoid. It is a cannabinoid. What is it? What is it used for? It has an anti-emetic property. It has an anti-emetic property. Okay, and it has an effect, that is, it stimulates the appetite. It stimulates the appetite. Okay, and it has sympathomimetic activities also. It can cause paranoid reactions. It has these adverse effects. Okay, tachycardia, palpitations. Okay, I taught you a long time back. How will you be managing a GERD? What are the strategies to manage GERD? Yeah, especially with AIDS patient. Very right. But I was asking what is dronabinol. Okay. So can you tell me how to manage a GERD? What are the strategies? Pharmacologically, we are asking you. So we have two strategies for the management. Either we can decrease the acid production or we can increase the motility of the GIT. Okay, so use a prokinetic drug and also use some acid decreasing production PPI. So what is, if someone is having vomiting due to cisplatin therapy, which drug will you give? Someone is having cisplatin induced vomiting. We are giving what? 5-HT3 blocker. 5-HT3 blocker. Okay. But if someone is having a delayed one, but someone is having a delayed one, so what will you be giving? Aprepitant. Okay. And also you can use palonosetron. Palonosetron is also effective in delayed MSS. Okay. So can you, by the way, can we know what is natupitant? Natupitant. Natupitant is a NK1 blocker. NK1 blocker. It is an NK1 blocker, but it is central penetration power. It can enter the brain. Okay. So never given with warfarin. Okay. So are we clear? Is there any doubt? Okay, let us ask you some one-liners. Okay, let us take our brain towards the drug of choices. Okay, simple drug of choices. So don't open the copy. Okay, don't cheat. Okay, just tell me what is the drug of choice for gastric ulcer? Drug of choice for gastric ulcer, it is proton pump inhibitors. What is the drug of choice for gastroesophageal reflux disease? GERD. Again a PPI. What is the drug of choice for post-operative vomiting? Ondansetron. What is the drug of choice for cisplatin-induced therapy? If I am having a cisplatin-induced vomiting, what is the drug of choice? If it is an early vomiting, then I will be giving a 5-HT3 blocker. But if it's a delayed vomiting caused by the cisplatin-induced, then I will be giving aprepitant. It is a drug of choice. Okay, hepatic encephalopathy, drug of choices, lactulose. Ulcerative colitis, drug of choices, 5-amino salicylic acid derivatives. Drug of choice for pregnancy, vomiting, pregnancy, morning sickness. So it is doxylamine and pyridoxine, isn't it? So what is the prophylaxis for motion sickness? Prophylaxis for motion sickness is hyoscine. Hyoscine is the prophylaxis. So can you tell us NSAID induced peptic ulcer? And sorry, NSAID induced ulcer is there. So which drug is drug of choice? PPI. PPI will be drug of choice. Okay. What is the drug of choice for H. pylori associated peptic ulcer? The drug of choice for H. pylori associated peptic ulcer? Yeah. Lansoprazole, amoxicillin, and clarithromycin. I taught you LAC, isn't it? LAC therapy. That is the drug of choice. If someone is having a levodopa-induced vomiting, what is the drug of choice? Domperidone. What? Domperidone. Remember. Domperidone. Is it okay? So if someone is having vomiting associated with migraine, yeah, migraine associated with vomiting, so metoclopramide. Migraine for M for metoclopramide. Okay, metoclopramide. We have last 5-6 questions, I think, and then we finish this session. Can you tell us what is diphenoxylate? Diphenoxylate. Diphenoxylate is a opioid. But the problem with it is addictive. It is addictive. So that's why we give atropine with it to prevent the abuse. Okay. Remember, it is contraindicated in infective diarrhea. It is contraindicated in infective diarrhea. Okay. Can you tell us the things used for the management of constipation? Things used for the management of constipation? Yeah. Things used for the management of constipation. So you can give you first management is you have to give high fiber diet. You have to give high fiber diet. I have taught you in pharmacology, and you have to increase the fluid intake and you have to do regular exercises. That is the best way to prevent the constipation. So you may require some laxatives also, like you can give some stimulant purgatives, you can give some prokinetics, you can give osmotic laxatives, you can give bulk forming laxatives like psyllium, like bran. You can give for surfactant also some stool softeners like docusate, paraffin, mineral oil, or you can give PEG. PEG is a polyethylene glycol. It's an osmotic laxative, isn't it? So made from that non-digestible sugar and alcohols. So we have also some osmotic saline of laxatives like magnesium sulfate, magnesium hydroxide. Okay. So we have learned it in our lectures, in the previous lectures of pharmacology. So can you tell us something about hyoscine? What is the hyoscine used in the gastro drugs, where we are using it for the prophylaxis of motion sickness? Okay, motion sickness. So can you tell us some anti-H. pylori drugs? Anti-H. pylori drugs. So which are the anti-H. pylori drugs? We have metronidazole, isn't it? We have tinidazole, we have amoxicillin, we have tetracycline, we have clarithromycin, we have CBS. What is CBS? Colloidal bismuth subcitrate, and omeprazole and lansoprazole. Okay. Can you tell me, if I want to heal an ulcer, which drugs can I use? I want to heal an ulcer. Sucralfate. Okay, very nice. Can you tell us what is the most potent H2 blocker? Most potent H2 blocker. Famotidine. Okay, very nice. So can you tell us some antacids? Names of some antacids. Names of some antacids. They include magnesium hydroxide, calcium carbonate, aluminum hydroxide. Okay. So I hope this session was helpful to you. We end the quiz session here. This was a rapid review for your entrance examinations, people preparing for the postgraduate exams and for AIMS and INICET. So you can listen to these lectures, on a 1.5x or 2x mode, so that you can rapidly revise the gastro drugs. I would be making more sessions in the upcoming sessions. So if you haven't subscribed to my channel, kindly subscribe, and thank you very much. See you. Bye bye.